Welcome to Retina Health for Life from the President's Corner, brought to you by the American Society of Retina Specialists. I'm your host, Dr. Tim Murray, coming to you from Miami. On each episode, we'll bring you inspiring conversations about your sight and the special role the retina plays in making healthy vision possible. We'll hear from expert retina specialists as well as directly from patients about living life to the fullest with retinal disease. Join us and learn how to safeguard your retina health for life. Welcome to the American Society of Retina Specialists, Retina Health for Life from the President's Corner. On this episode, we're going to talk about gene therapy, which is leading to breakthroughs in saving and restoring vision for people with retinal disease. Today, I'm happy to welcome my colleague and fellow retina specialist, Dr. Thomas Ciulla of the Midwest Eye Institute, to discuss this exciting scientific advancement. Dr. Ciulla is a world's authority on gene therapy applied to the eye, and it's truly a pleasure to have him join us. Welcome, Tom.
Thanks for having me, Tim. Pleasure to be here.
Really a pleasure. So, Tom, these videos are really focused to reach out toward our patients and our families. And I think one of the excitements in our field and what has been driving a lot of our research interest has been gene therapy. I continue to get asked about when will gene therapy be available for me virtually every clinic day. So I'm curious if you have that experience in your clinical practice. And then could you take us into really what drove you to an interest in gene therapy, and then take us again into what gene therapy really is for our patients?
Well, sure, absolutely. So patients are very excited about all that's happening in retina. Retina is an incredibly interesting field with all sorts of innovations, with therapies like gene therapies, with diagnostic tests, and even with surgical innovation, where we can help patients so much better now than we could back when you and I were residents, Tim. I got interested in retina and research when I was doing my residency at Mass Eye and Ear in the 1990s. And I was exposed to an absolutely brilliant group of young faculty members who were working on angiogenesis under the legendary Judah Folkman. And the entire ecosystem was really a special place because you had all these innovative, hardworking faculty who ultimately helped develop anti-VEGF therapy that we all use in our practice every day. And oftentimes we can restore sight in patients with macular degeneration and diabetic retinopathy. And this really inspired me to pursue clinical research in retina. Later on, when I joined the faculty at Indiana University, it was also a really exciting time. It's the only medical school in the state and the largest medical school in the country with 11 campuses. Back then, we had an angiogenesis lab, and we started clinical trials, working on early trials of anti-VEGF. And what still sticks in my mind now, more than 20 years later, is that I vividly recall how we had patients in these trials, and I always thought we were just going to help slow down their vision loss. And I realized what a remarkable innovation that we had stumbled upon when patients started coming back to my clinic with better vision. So it was a really exciting, heady time, and this really inspired me to continue with retina and retina clinical research. And I got essentially just hooked on this exciting innovation. And so I think, since then we've come a long way, and, now we're talking about gene therapy. And so I think you asked me about gene therapy and what it is. And, basically it's this rapid evolving technique, and it essentially manipulates the genes in patients to treat underlying disease. Typically, genetic material is introduced into the cell, and that restores production of a protein that may otherwise be faulty due to a patient's DNA.
Yeah, I think that's really fascinating. And I think that, you've had two really great opportunities to partake in therapies that are literally game changers. And I agree with you. I think when you start in a lab like you did at Mass Eye and Ear, and like I did when I was at Johns Hopkins, I think it really just generates that kind of interest to continue to explore. Some of our colleagues explore by staying in laboratory fields, but some of our colleagues want to translate that research, and I see you as an excellent example of that. So you're taking research from the laboratory and really moving that into clinical care. And for me, that's the gold standard. I'm always excited about that. So in gene therapy, it sounds so simple that you first find the defective gene and you just replace it. But I think that you and I both realize the devil's in the details. So ophthalmology really has been a leader in sort of many areas in medicine. But I think that you and I both would agree that the first gene therapy to be effective and FDA approved is for the eye. So could you tell us a little bit about what that disease is and what that therapy is, and how do we treat the involved patients?
The disease is Libre congenital amaurosis, and it's a really rare, absolutely visually devastating disease. It's caused by a variety of gene mutations in the RPE65 gene. And that's a gene that produces a protein which plays a key role in our visual cycle. It's partially responsible for vision. Classically, Libre's congenital amaurosis presents in infants and children with loss of night vision, loss of peripheral vision, and ultimately these children lose their central vision. Gene therapy essentially has allowed us to add a normal RPE65 gene that restores the visual cycle in these patients. And it's really essentially a very life-altering therapy for these patients and their families. During the approval process, I got to go to the FDA and hear patients and their families give testimony of how they could see their parents' faces for the first time. They could see stars in the sky for the first time. They could go trick-or-treating for the first time, or even see snow for the first time. But I think you mentioned adding a gene to cells that are affected, and that's essentially what we're doing with this first gene therapy. And I just wanted to back up a bit and just explain that, as you mentioned, the devil's in the details. So gene therapy can be one of many forms. What we're talking about is something called gene augmentation. Again, adding a gene to a cell to replace a missing or defective gene. But there's other types of gene therapy in the news. Another type, for example, is gene editing, when we revise the existing genetic code in a patient's cells. And there's also gene inactivation, when we silence a faulty gene. So basically, Libre congenital amaurosis with the first therapy, Luxturna, is a form of gene augmentation therapy.
So that's fascinating, but as you've said, because Leber's is so rare, we touch a very small part of the population that has this disease. It's an incredible advance for that disease and for those patients, which is interesting. But we're also very aggressively, as you've been involved, looking for other therapies. And I get approached about a very common disease day in and day out in my clinic, which is age-related macular degeneration. There's been some excitement about the possibility of a gene therapy for age-related macular degeneration. Can you take us through that a little bit? What are your thoughts and where do we stand?
Yeah, great question, really interesting concept. So we started this conversation tonight with talking about anti-VEGF therapies for diseases like wet macular degeneration and diabetic retinopathy. These are some of the most prevalent causes of irreversible blindness or central blindness in the industrialized world. And as you know, we can inject therapies in patients' eyes. Unfortunately, they often have to come back almost monthly and sometimes indefinitely for that treatment. So interestingly, gene therapy can be used to have the retina produce its own therapy in what we call a biofactory approach. So for example, instead of administering monthly injections of these anti-VEGF therapies to patients with macular degeneration or diabetic retinopathy, a one-time gene therapy could theoretically lead to lifelong production of medication within the eye and basically free patients from that treatment burden of monthly injections. So that's a very exciting concept. And it also shows the versatility of gene therapy. We mentioned treating Libre congenital amaurosis, a very rare, in fact, an ultra-rare disorder with the first approved therapy, Luxturna. And on the other end of the spectrum, use gene therapy as a biofactory to treat very common disorders. So it's a very versatile modality. And I think the entire retina community is eagerly looking forward to ultimately using this on patients. It could benefit patients and their families in so many ways.
Yeah, it's interesting too because labor strikes at birth, and macular degeneration strikes often in our seventh, the eighth, and ninth decades. So the same concept of gene therapy targeting both spectrums of life for our patients. I think my patients are very excited about the concept of a biofactory, and they can understand that really intuitively, that their eye could be placed in a position to make something that helps. And what's fascinating, I think, and you do also, I believe, is that this can be a treatment for multiple diseases that pivot around alterations in VEGF. So that's kind of super exciting. So maybe it'll work in AMD, maybe it'll work even better in diabetes. Any thoughts on that?
We often treat patients now who have swelling in their macula from diabetic macular edema. But what's really interesting is to be able to treat patients with a biofactory therapy that produces an anti-VEGF. And these would be patients who have diabetic retinopathy, but not diabetic macular edema yet, or not proliferative diabetic retinopathy yet. So we could potentially treat patients with early stages of diabetic retinopathy. And that would actually prevent them from even having the disease in the first place, or progression of the disease in the first place. So ultimately, it could be almost a comprehensive strategy to prevent complications of diabetes and diabetic retinopathy with respect to proliferative retinopathy or diabetic macular edema. So I think that's very exciting as well. It actually could alter the course of disease for patients.
Yeah, I think it's fascinating to go from one specific gene defect that treats one very specific disease to a concept that will enable us maybe to treat patients with multiple stages of multiple diseases. So that's incredibly exciting. Tom, when you've looked at this, the first therapeutic strategy with Luxturna requires a surgical placement of the drug underneath the retina, which has been technically challenging in some instances. Can you take our patients through and their families, what are different approaches to get gene therapy effectively into the eye, and where are you thinking we would like to go as a best case approach?
Great question. So obviously we want the gene therapy to essentially treat the correct layer of the retina. Currently, we do surgery where we perform a vitrectomy. We inject the gene therapy under the retina in order to expose the photoreceptors or rods and cones and the pigment cells that support the rods and cones to the gene therapy. That is a surgical procedure in the operating room. It does have some risk, but ultimately, when we're treating patients with diabetes or elderly patients with macular degeneration, it would be best for the patient to be able to do this in an office setting. So another strategy is to treat with an intravitreal injection. There's at least one company looking at that in a clinical trial. And another strategy is to treat in the office with a suprachoroidal injection. And there's another company assessing that in a clinical trial currently. So basically we have the sort of the standard surgical procedure in the operating room, and then we have two office-based procedures that are currently in clinical trial.
Yeah, so from a retina specialist perspective, many of us are very comfortable in the operating room underneath the retina or on the retinal surface, but virtually every retina specialist is comfortable with an intravitreal injection. And that's how we treat the majority of our patients with complex diabetes and complex advanced age-related macular degeneration. So I can easily see how transitioning to an injection in the office that would have a sustained effect would literally fundamentally change the management of our patients. I think that would be in some ways what we would all be hoping for. The suprachoroidal delivery is a little bit more complex, but is a very doable procedure in the office also. but I keep pushing toward that intravitreal injection. So that's where my hopes will lie for my patients.
I agree. It's very exciting, and I think there's multiple shots on goal here. So hopefully, over the next few years, we'll have an entirely new spectrum of very beneficial patients for treatment.
So one of the issues with gene therapy that has come up with the Luxturna approach is when are patients best benefited by surgery? So are you thinking that there are going to be some changes in the way we approach our patients, either at the age of treatment, or do you think maybe patients will benefit from a wider application of the gene therapy delivery? Are there any thoughts about how we look at that? Are patients, is some age too young, Tom, for patients to have gene therapy?
Probably yes. We know that the eye isn't fully grown until about age 2 or so. There's still cells undergoing maturation in the eye. So we want to have the eye, essentially be fully grown with anatomic landmarks that are more readily familiar to retina specialists, even pediatric retina specialists. The surgery may have more risks in younger patients. On the other hand, if you wait too long, there's a risk of amblyopia, where if vision isn't restored in a child earlier in life, their brain never really learns to see, so to speak. So it's probably around age 3 to 4. It may be the best time to start considering this therapy. For Luxturna in the clinical trials, that was the lower limit of age in those patients. So I think that's probably where we'll start. But obviously, we have a lot to learn, and going forward, things will evolve as they have in retina.
So I think that's fascinating. One of the things that I think that happens when you develop first treatments is that we're able to apply some advanced imaging technology now to our patients, even at very young ages. And I think in the past, sometimes we would see these children and it would be, we would observe them, but we wouldn't really be focused on providing ongoing evaluation. I think the game changer for this has been the ability to do gene testing on children, young children especially, that may have alterations that are previously unrecognized. So could you comment about if I'm a dad and my young son has this very rare diagnosis, is there a benefit for me to ask that there be a genetic screening test done? And how do we do that?
You bring up a great point. The field has evolved with respect to diagnosis in a tremendous way. Classically, clinicians would examine the patient very carefully, and there'd be almost a pattern recognition process in the clinician's mind. And then as retina has evolved with diagnostic technology, we became better at applying office-based diagnostic technology like imaging, like OCT imaging and angiography. And now we're moving into an era of genetic diagnosis. So it's the ultimate personalized medicine. So absolutely, if a patient has a retinal disorder at a young age, it would be potentially very beneficial to undergo genetic testing. That would allow a molecular definitive diagnosis, which in turn would allow for appropriate counseling, appropriate understanding of the prognosis going forward, and ultimately allow a patient to be screened perhaps for clinical trial, be it with gene therapy or other therapies currently undergoing assessment. And even if a molecular diagnosis is established and there is no current clinical trial, there are multiple clinical trials planned, some of which are gene specific, and there are some non-gene specific gene therapies that are being developed and maybe in clinical trials soon.
So I think the point of having your child evaluated on a molecular level for the gene therapy potentials is critical. And that's kind of new for us. And I think that that's really important for our patients and their families to know that that option is available. I also think that there are specialty centers that have more experience potentially in both the evaluation and treatment of patients. There's been some discussion about whether children in particular benefit from being managed in a specialty center. Do you have any thoughts on is that type of unique gene therapy that requires a complex surgical approach? Should we think of that maybe in specific centers where something that may be much more traditionally available to other retina specialists like intravitreal injection or suprachoroidal placement may broaden the access for patients?
Exactly. Anytime there's a disruptive innovation in healthcare, oftentimes these disruptively innovative therapies are offered in large hospital systems that have the capital to buy all the equipment and the specialized training. And then over time, these disruptive innovations slowly become, in a way, commoditized, where the technology becomes less expensive, where the training becomes more widespread. Particularly in this age and era of the internet, information is disseminated so quickly. So I think initially, with a very new therapy, it's very common for it only to be offered in specialized centers. But over time, the therapies, as I mentioned, they become almost commoditized to the point where more and more clinicians in practice have it in big cities initially, then smaller and smaller cities, and ultimately the technology gets widely disseminated, and that enhances access for patients. So I think this is a good thing, and I think ultimately, subretinal surgery, gene therapy will disseminate to more local providers. And then, as you and I were discussing, once we have office-based administration procedures, it'll become even better with more widespread access.
Yeah, I think that's exciting. So, like everything else, first there's maybe limited access, as we've said, but then it broadly disseminates as it becomes more approachable outside of an academic center or a specialty center.
Absolutely.
I tell my patients that that I'm comfortable talking to them about existing and potentially future gene therapies, but not every retina specialist may be. So, where should we push our patients to look for additional information that's a little bit more appropriate than some of the general Google sites that get looked at for gene therapy?
Well, the best source of information, of course, is the American Society of Retina Specialists podcast hosted by Tim Murray. But of course, the American Society of Retina Specialists has a lot of information on the website for patients, as does the American Academy of Ophthalmology. And of course, the Foundation Fighting Blindness has been very involved with inherited retinal disease and gene therapies. Most importantly, patients should seek advice from their own primary retina specialist who has access to these sources and beyond.
So I think especially for parents that have a young infant that has a complex diagnosis, I really think that's the opportunity to make sure you're seeing somebody that has specialty experience, either a pediatric retina specialist or a pediatric ophthalmologist that has specialized in inherited retinal disorders. Because to me, that's such a pivot point early to better understand what may happen for your child and what the options are for you at a time when options are changing very quickly. And I also like the National Eye Institute for the National Institute of Health as a resource for patients. They are very focused on how they present information, and it's been very well evaluated, as it is for the American Society of Retina Specialists. So Tom, being the person that's really actively involved, what are you most excited for in gene therapy over that next maybe 2-year horizon?
Well, I think, as I mentioned, some of these biofactory approaches could have just an enormous impact on our entire field, and an enormous impact on patients and their families. Having a gene therapy that sets up a biofactory in the patient's own eye to produce its own therapy could really change the course of disease for patients. It could change essentially how we practice, and it could have a huge impact on society, on the ability for senior citizens with macular degeneration to live independent lives for a longer time period, for diabetic retinopathy patients to avoid some of the complications of diabetic retinopathy we discussed. And even if these therapies aren't necessarily one and done therapies, even if they don't work as well as we hope, if they even just decrease the treatment burden, that would be a huge benefit to patients and their families and society. So it's a very exciting time for retina. And I think, as you mentioned earlier, you and I have been very privileged to be in a field that has seen so much disruptive innovation. I started my career, and I think you started your career around the same time, where we saw anti-VEGF therapies come of age, and now to think, in a 2-decade span, to see gene therapy come of age in retina, and really, it's very exciting to think that the very first gene therapy for a genetic disorder in all of medicine happened in retina. And it's really just amazing to witness that. So I think we're on the cusp of another huge paradigm change, and it's just going to have tremendous impact on society. And I think it will benefit patients greatly.
I agree with you. I think this is going to be an exciting, next couple of years. And I do think that it has the potential to shift how we manage virtually all of our patients in a retina specialty practice. So that's incredibly exciting. And I also think, as much as it speaks to the good research and relationships that we've had, we also are blessed in retina of having very brave patients and very brave parents and family members who are willing to let us treat their children with novel therapies that are not yet understood. It really is an interesting concept to think about something going from a laboratory into animal research, and then being able to treat the first patients with that. I think it's all of what you and I both went into medicine for. So Tom, I'd like to thank you for joining us at our ASRS Retina Health for Life podcast. Thanks for tuning in to Retina Health for Life from the President's Corner. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcast, Google Podcast, and Spotify. For even more information about safeguarding your vision for a lifetime, visit asrs.org/patients and follow ASRS on both Facebook and Twitter. Retina Health for Life is made possible in part through generous support from the Foundation of the American Society of Retina Specialists, Allergan, Genentech, Novartis, and Regeneron Pharmaceuticals. See you soon.